Hello guys, today I'm going to discuss one important presentation, or you can call it as a prototype case for the lateral recess stenosis. Lateral recess stenosis is a quite important case because for endoscopic decompression, most of the time it is missed as a diagnosis, and because it looks very small on the MRIs. Uh, when we see the MRIs, axial sections and sagittal sections, we at times we hardly see any compression over the nerves. But if you closely look at the sections taken from the lateral recess, if you closely look at the lateral recess in the axial sections, you may find the traversing root getting compressed over there. Most of the time, when the radiologists also when they measure um, the diameter, axial diameter of the spinal canal, they take it from the center, and it looks like a good huge canal. But the lateral recess stenosis is quite common, uh, and also it is most like I can say that the patient presents with a presentation which is not relating to the MRIs, which doesn't relate actually with the MRIs. So what happens is that these patients are more symptomatic as compared to the MRI what we see. Most of these patients will have severe radicular pain. Their SLR will be like maybe just 20-30 degree. They may have sensory deficits, motor deficits, and when we look at MRI, we don't see much big herniation over there. And that is why it is very important to understand what is lateral recess and how to decompress it. That is again very important because the traditional method of doing endoscopy is not applicable over here. So we have to think um, out of the box to identify this lateral recess and to decompress it. So this is what we are going to do. MisEpp is the minimally invasive spine endoscopy pain procedure. I'm going to show you the prototype example of this lateral recess decompression. Uh, so this is a MRI of this patient. If you look at here,
it's 22 hours.
if you look at here, this is the MRI of the patient. Um, this is the left side. This is taken at the L4, L5 level. This is the left side. And you can see the thecal sac over here. And the traversing root is somewhere over here. And this is the herniation over here with the traversing root entrapped within the, we can't make out from here where's the traversing root. It is compressed somewhere over here in the lateral recess. On MRI, we have to see the sagittal sections, not taken from the center, but from the parasagittal regions. If you look at over here, you can see the traversing roots over here. But look at this L4, L5. At this, we can see there's a severe compression of the traversing root over here. This is L5 root, you can see here. There's small herniation over here, but it is not compressing the S1 root over here. That's okay, this is open, but this is the one which is compressed over here. Now look at this fluoroscopic image. Now, where is the lateral recess on the fluoroscopy? That is again important. Now, if you look at this is the inferior articular process over here. Lamina going to the inferior articular process. This is the superior lamina and going towards the superior articular process over here, right? The junction, the intersection of this inferior articular process and the superior articular process forms the medial border of the lateral recess. And the medial border of the pedicle, this forms the lateral border of the recess, lateral recess. So this is the area where we have a traversing root. Traversing root comes like this. So in the center, we have this dural sac. Okay. At the level of the disc, again, we have a dural sac over here. Okay. And as it approaches towards its foramen, the nerve root comes out of the dural sac. It fits into the groove, which is under surface of the pedicle. It fits into the groove, and then it goes out and exit over the foramen here. So this is the area of the lateral recess. which is bounded by the superior arterial process, inferior arterial process, that means the facet joint. Posteriorly, it is a disc over there. Middle, it's a ligamentum flavum. So this is all bounded by very strong structures. So there is hardly any room for the nerve to mobilize over there. So that is the reason why we have a lot of severe compression or severe symptoms, even if there's a minor herniation at the level of the lateral recess. So lateral recess is not limited to the disc herniation. It is not compressed. The nerve traversing route is not compressed just because of the disc herniations, but also there may be some osteophyte formation coming from the facet joint, or maybe the ligamentum flavum buckling inside. The ligamentum flavum goes inside over the lamina over here. It covers the intersurface of the facet joints. So this is part of the flavum which may go inside and may cause compression of the lateral recess. The issue is that upper areas we have limited access to this lateral recess. When we go interlaminar, through transforaminal foraminal, it is difficult to decompress it. It is very difficult to decompress this. If it is flavum is there, if the osteophytes are there, it's difficult to decompress it from here. Interlaminar is the best approach to decompress from posterior also, and if the disc is there, we can decompress the disc also. So normally I choose, mostly I do interlaminar case in such cases, and this is the area we have to clear, and we'll see how to do that. So you can see this spectral diagram where you can see this, the dural sac is there and the nerve root is coming out of the dural sac, is going over here, and this is the area of the lateral recess. This is normally what we do in our cases. We give the caudal epidural first to basically caudal analgesia. Just 1% of the lignocaine with 0.25% of bupivacaine, 10 ml. We inject contrast. We see that we are covering this dural sac over here. This is important because we are going to handle the dural sac over here and the nerve roots over here. So when we are pushing them medially, that may cause severe pain. So we have to anesthetize this area. Analgesic effect will be there. To handle that, 1% lignocaine and 0.25% of bupivacaine is sufficient. So this is what we do. We give caudal epidural first, and followed by we just give it a 22 gauge needle. We go towards the facet joint. So here we have a capsule of the facet joint. We go in towards the facet joint. We inject some 2% of the lignocaine. This is basically when we are moving around here. When our scope and our working channel is moving over here, we can see this facet joint moving. Okay, so this movement of the facet joint capsular stretch will cause pain to the patient. So just to avoid that, so that patient is comfortable, uh, we just give local anesthesia over here. So to anesthetize this entire facet joint. And this is the incision site you can see here. Now in this case, we saw that the disc is herniating, disc is coming out, and it is encroaching in this part of the this lateral part. This is the lateral recess part. So the disc is entirely over here. In the midline, there's hardly anything. It starts from here and goes to over here. So this is the entire area where we have a lateral recess and we have this herniation over here. So this is the what we want to target. We want to open this area. This is the area we wanted to open, right? Because we know that disc herniation is over here. Here is a dural sac. Somewhere here is a dural sac. Okay, so my incision would be somewhere over here, and I'll open this area. We'll have to open this area to reach the fragment. This you can see that this is how I'm placing my dilator. After putting the dilator over there, you can see this is the medial border of the inferior arterial process. Okay, the medial border of the superior arterial process, and we are just medial to the junction of the SAP and the IAP. So this is where I'm placing my dilator. Over that, I'll put a sleeve in the lateral position. I'll check my position first, the direction first. So this is the area of the interlaminar window over here. You can see the dilator is over here, and then we'll go put our sheath over there, working sheath over there. Okay, once that is done, then We go to the next step. The next step is your putting the scope inside. So when you put a scope inside, we see our muscle layer. We remove the muscle layer. Once we remove the muscle layer, then we see the ligamentum flavum over there. So this is the area where we have the inferior articular process over here. Here's the lamina over here. The superior articular process is over here, somewhere here. Right now we cannot see because we are just cutting the flavum. We'll start cutting the flavum first. So what I'm doing is basically I'm just going medial to the junction of the inferior articular process and the superior articular process, and I'm cutting the flavum from there. This is the superficial layer of the flavum. You can see this is a quite a bulky flavum over here. Uh, so it has basically three layers. You can see in the interlaminic assays. The superficial layer is like quite bulky. It's a yellowish component. As we go inside, we see the fibrous part of the ligamentum flavum. We start seeing the fibrous part of the ligamentum flavum once you remove this. This is the fibrous part of the ligamentum flavum you can see here now. That's the fibrous part. Okay. So what we have done is I just kept this part open. I'm not going to open the epidural space. I'll work open this area first so that we don't have any bleeding over there. I try to preserve the innermost layer of the flavum till the time I do the other work over here. So this is the best strategy so that you don't have to deal with the oozing of the blood from the epidural space, epidural vessels. Okay, so this is the inferior arterial process here. Superior, the lamina is over here. This is somewhere is the superior arterial process. Now you can see that I created some hole into the ligamentum flavum so that I can put my carison inside to basically shave off the SAP. So we'll do with this RF. We just clear this area. Now once we clear that area, then once we remove the flavum, the major part of the flavum, and now you can see here, this is the this is the inferior arterial process over here, IAP. The one which is going over here under surface is the superior arterial process, SAP. The lamina somewhere here. Lamina, this is the junction of the lamina and the superior arterial process. Now, if you look at this bone, this is like a spongy kind of bone. It's a very not a very hard bone. It doesn't have any cancerous portion over here. It's a soft kind of bone. This superior arterial process part of the SAP. And this is the flavum over here in the middle part. So once you identify that, now you can see this, the movement is happening over here. This is SAP, inferior process, SAP. And now we start cutting the flavum to open the epidural space. So the nerve root is somewhere here. The traversing root is somewhere here, behind this, behind this. This is the area of the traversing root, so we'll have to open this area. I'm not going to paracentral area, not going to central area. I'm just working towards the facet joint. This is the facet joint. You can see this is movement happening at the facet joint over here. So this is what I was telling you. Once you go with the scope inside, once you put our sleeve inside, there will be movement of the facet joints. Okay, so that is the reason why I gave local anesthesia over here, so that the patient is comfortable. I do most of my procedure under local anesthesia, so patients are totally fully awake. We keep talking to the patients most of the time. If the patient is apprehensive, at times we just give midazolam or sometimes 50 mics of fentanyl. That is all what we give. But we don't give GA at all. We always want our patient to be awake. So once you remove that, once you create some space, then now you can see here we are removing some part of the SAP, superior articular process, because I know that nerve root is somewhere here. I have to cut this part to reach the traversing root and to reach the disc which is there. The disc is somewhere here. The disc is somewhere here. But first I'm trying to identify, I'm opening the lower part. I'm trying to open the lower part. Very easily we can compromise this part of the SAP. This is actually not helping us. It is just lying over there and it is not contributing actually into the formation of the facet joint. So we can compromise this part. We want to preserve other part of the facet joints, inferior articular process and the cancellous and the cortical part of the facet joints that we want to preserve as far as possible. So this is the innermost layer of the, you can see here, innermost layer of the flavum. And this is the area of what we have cut over the SAP to create some space over there. Now I'm going towards the junction of the SAP and the superior lamina of L5. That's the junction of the superior articular process and the lamina over here. Now you can see there's a lamina over here. This is the lamina of the L5. Okay, and you can see this epidural space over here. Also, if you notice it over here, you can see small the the dural pulsation we can see over here. That's the dural pulsations. Still, I'm preserving the flavum till the time I do my bone work. I'm trying to preserve the flavum as far as possible. This is a part of the superior lamina of L5. And you can see here somewhere is the, now I'm going towards the flavum. This is the part of the flavum I'm removing. At times, people also use with lignocaine, but I also started doing that. But in the middle of the procedure, the BP goes like starts shooting. The absorption will take some time from the epidural space. So by 15, 20, 30 minutes, the patient will have peak of the blood pressure. And that is the time when we are opening the flavum. So that is why I stopped using with adrenaline, lignocaine with adrenaline. Earlier, I used to use that in the epidural space. So I stopped using it because when you open this, that is the time when we want to have a good control over the blood pressure. So this is how we are removing the flavum. Now you can see this is the flavum which has gone inside the facet joint. This is the flavum which is coming from the under the surface of the facet joint. That's the flavum. So once we remove this flavum, once we cut this superior articular process, now we'll start seeing our traversing root over there. Now if we look at here, this is what we have removed. So this is a disc area. Now you can see the disc. This is a disc over here. That's a disc. So before handling the disc, I want to be very sure that I have a good access to the disc. So I'll make it the margin smooth as far as possible. And here you can see the traversing root over here. That's a traversing root here. Under the epidural fat. That's the epidural fat. And if you look at this, this is the all fibrous tissues. This is what we expect, right? So whenever there's a disc herniation, we expect some fibrovascular growth which happens inside, right? This is what fibrovascular growth is. So you can see a lot of blood vessels over there, over the disc also, encroaching towards the nerve root. And that is the reason why we have radiculitis, okay? Neuritis or radiculitis, what we call. So this is the inflammation part. You can see a lot of inflammation over here. So this is a fibrovascular growth which encroaches and entraps the nerve over there, and that causes severe pain. So this is disc area. This is a traversing route over here, and this is a fibrovascular growth which happens in a acute and subacute cases. So before handling this area, this is what I normally do is that whatever vessels are there, I coagulate them so that if you start handling them without coagulating, what will happen? It will start bleeding, and you'll be wasting a lot of time in controlling that bleeding. So it is better to control this bleeding by just coagulating all the vessels, whatever are visible. There will be some ooze from the bone which you cut that will be there, and this is what I'm doing. I'm just blocking these, coagulating all these vessels into the epidural space over the disc. Okay, so this will definitely reduce your all the bleeders. So now we have good enough rooms available for us. The traversing route is here. This is a fat over there, epidural fat. Okay. This is lateral SS area. This entire is the lateral SS area. This entire is the lateral SS area. So we have completely exposed the lateral SS. We're just trying to control the bleeders over there. Take a take good time over here. Don't be in a hurry. The moment you see the disc, don't jump over the disc. Now you can see this beautiful traversing route over here. It is totally compressed over here because of the disc. This part is a little free, but this part is, you can see, it's bulging part. It's bulging. Okay. Why it is bulging? Because there's a disc herniation just behind this. Just behind this is a disc herniation over here. We can see some movement of the nerve happening here because now we have cut the flavum. Since we have cut the flavum, that's why it has some room available. Otherwise, it was totally compressed between the flavum and the disc herniated disc cover in the lateral recess. So these are the bleeders what we expect once we open the space. That is what we expect. Takes some good time to coagulate all these small vessels. You can see this bulging root, root taking a shape like this, convex shape. Complete convexity is there. There's a lot of pushing is there from the this part. So now we are just cutting the part of the disc which is herniated out. What happens in the subacute cases? It forms a layer around the extruded portion. So I'm cutting this part of the disc, but I'm hitting the bone over here. So that is basically I'm hitting the um, body of the L5 over here. You can check it on the fluoroscopy, and then you can go up. This is what I did. I just checked on the fluoroscope. Now I started going a little up, and I'm making a small hole into the herniated portion. This is how we are cutting it. And now you can see this, we have opened a part of the extruded material over here. Before going for the removal of this, you can open it further, slightly open it, and you can see this is the big chunk of the extruded material which is there. So that's the entire fragment has come out in one go. This is entire fragment you can see here. It's a big fragment. It's a big fragment. And you can see this is completely empty now. We're just straightening out the nerve root. And also you'll start seeing the pulsation of the nerve roots. The moment you remove this, you'll start seeing the pulsation of the nerve roots. If you look closely over here, you can see the pulsation of the nerve roots now. Don't try to remove excessive disc material from there. Whatever has extruded out, that we have removed completely in one go. We don't have to do much of the disc work here. Everything is been taken care of. So nerve root is completely free now. You can see here, absolutely free traversing root. Here is the disc. Here is the uh, dura over here, and this is a root which is coming out of the dura. This is axillary portion. This is axilla. Axilla. This one. This part is axilla. Okay, and the dura is somewhere here. From dura, this root is coming out into the lateral recess, going towards the foramen. That is all. So uh, again, I would say that it's a wonderful procedure. You must learn this procedure. A lot of time we just try to remove a lot of disc material, but that is not required in most of the cases. Target a fragment. Target fragment. Don't target a disc. This is what people do a lot of mistakes, that they try to remove as much as disc as possible. We don't do that. We just go for the disc which has come out, extruded portion, whether it is transforaminal or it is interlaminar, whatever it is. Create a good space for us. Work on that first. Target your fragment. Where is the fragment? Accordingly, you have to select your entry point. That is the most important. If you select your entry point correctly, you'll have to do less bone work. You'll have to do less flavum removal. You can do with the minimal invasion. Okay, guys. So this is all about lateral stenosis. So I'll stop here. Thank you very much.